welcome to all the people who are connected to this webinar. And I'd like to thank Lupin Pharma for taking this wonderful academic initiative of bringing people together, where the specialists in a given area, they can share their experiences and the academic content with the practicing physicians. It's a privilege for myself and my team, AGI, the Gastrocity. I'd just like to brief about that AGI is now approximately a 5.5 years old institute. It's a group of very competent professionals, 4 gastroenterologists, Dr. Rajiv and Neeraj being 2 of them, who are being there in this platform today, 2 GI surgeons, and very competent backup with intensivists who are specialized in GI intensive care, anesthesiologists, GI pathologists, and radiologists. So already in 5.5 years, we have made a big mark in this whole region, not only in Punjab, but even I would say the surrounding states from J&K all the way to Delhi. And the team is so adept in academic activities that we have already been very active in different arenas. And when actually Lupin approached, we were actually more than willing to be part of this academic activity. So today, the topic which has been chosen is something really of great interest to the practicing physicians, and which is for few reasons. One, this is something we come across so commonly in our day-to-day practice, that is functional dyspepsia. 2, there are so many gray zones in both the diagnosis and in the management of functional dyspepsia, with the latest Rome 4 criteria subcategorizing into 2 distinct subtypes, one being called the EPS, another is called the postprandial distress or the PDS, which my colleagues will allude to in great detail in both the presentations. And then I think we'll be looking at the treatment options in a case-based fashion. So different cases where there could be certain overlap of one with the other and how to manage them appropriately. So with these words and what I think as introduction has already been given by Dr. Gajanan, I can tell both the speakers, both my colleagues, Rajiv being a senior colleague and Neeraj again the younger one, but very, very competent, very dynamic colleagues, both of them, good command over the language and the subject. So what we are going to have in the next, I believe, 50 or 55 minutes from now, we are going to have a great academic feast, where Dr. Neeraj Singla in a case-based fashion will take us through the pathophysiology and the clinical diagnosis part. And Dr. Rajiv later will take us through the treatment landscape with a special emphasis in the end on the role of ecoshiamide, which is a very specific drug for PDS, and it's a wonderful drug. And I think all of us will become wiser once we reach to the conclusion of this webinar. And question and answers will take once both the presentations are over. And with this, I invite Dr. Neeraj Singla with his presentation. Thank you.
Thank you, sir. First of all, a very good evening to everyone. I would like to thank Lupin, the whole team, for inviting me for this webinar, making me part of this. So I will be discussing about functional dyspepsia. We'll be discussing about 3 cases, but before that, so I will be discussing the pathophysiology of functional dyspepsia and with a special emphasis on early satiety and postprandial syndrome. So if we take dyspepsia broadly, so when we see the population distribution, 20 to 30% of patients with dyspepsia, they have some organic cause to their dyspepsia. So rest of the 70% patients, they don't have any organic cause. So they likely have a functional dyspepsia. So which we are going to focus today, this 70% group, which don't have any organic or any cause to the dyspepsia. So if we talk about the organic causes for the dyspepsia, so these can be peptic ulcer disease, there can be any gastric or esophageal cancer, so there can be gallstones, chronic pancreatitis, pancreatic cancer. So even patients with celiac disease or lactose intolerance, they can present with symptoms of dyspepsia. But we are going to discuss the functional dyspepsia group, so which is a major chunk in our routine practice. So they have neither a structural disease or any biochemical explanation for the symptoms. So coming to this group of functional dyspepsia patients, so the global prevalence ranges from 20 to 30%. So in a physician's routine practice, so there in the routine OPD, 20 to 40% patients present with functional dyspepsia. So why this wide variation? So this can be attributed to different diagnostic criteria used to diagnose functional dyspepsia and different geographical regions. So now coming to the symptoms. So how do these patients present to us in the OPD? So usually they come with either, as Sir has discussed, that they can be epigastric pain syndrome, so which include epigastric pain or discomfort, or there can be a second subgroup, which is a postprandial fullness as well as early satiety. So they can also have bloating sensation. Belching usually is part of gastroesophageal reflux, but these patients again can have this thing. Along with that, some patients can have nausea, vomiting, and they can have a weight loss. Probably they try to reduce their diet to reduce the symptoms, so that can lead to weight loss also. So coming to this Rome 4 criteria, so which defines functional dyspepsia. So there should be a presence of one or more of the following symptoms. So if the patient has bothersome postprandial fullness or bothersome early satiety, so this group combines to form the postprandial distress syndrome. On the other hand, if the patient has epigastric pain or epigastric burning, so this forms our epigastric pain syndrome. So patient can have either epigastric pain or they can have postprandial distress, but some patient can have an overlap of both of these. So the endoscopy should be classically, it should be normal. There shouldn't be any structural disease on endoscopy. The symptoms should be present from the last 3 months, and the onset should be at least 6 months before the diagnosis. So very important. So there are various dietary and lifestyle factors which can precipitate functional dyspepsia. So coming to the lifestyle factors, there can be associated stress, anxiety, which can aggravate dyspepsia. There is definitive role of smoking, any excessive tea, coffee intake, alcohol, overweight, obesity, or high performance exercise like HIIT, or they can precipitate dyspepsia. There are specific food items also, excessive fatty food, oily fried items, hot spicy foods, carbohydrate rich foods, or high fiber foods can also trigger the symptoms. So coming to some meal related factors, if the energy intake in single go, the meal size is like large, so that can also precipitate the symptoms. That's why we recommend the patients to take small meals, probably at a frequent intervals. The dietary composition again is very important. So if it is a high carbohydrate or high fat diet, so that can also contribute to the symptoms. So all these factors lead to visceral hypersensitivity, gastric dysmotility, which I am going to discuss in the further slides, leading to a meal-related functional dyspeptic symptoms. So if we see the broad pathophysiology, so there is some contribution by the CNS because of anxiety, stress, and there can be due to the due to the acid or wall distension, there is a peripheral as well as central hypersensitivity of the nerves. So there can be contributing gastroesophageal reflux by the gastric acid or bile acids, and there can be inflammation usually caused by H. pylori. So H. pylori is an important contributing factor to dyspepsia. We're going to discuss in the further slides. There can be associated duodenal inflammation by again the gastric acid or bacteria or viruses. So all these factors lead to either a decreased fundic accommodation, abnormal distribution of gastric contents, delayed gastric emptying, over distended antrum, leading to a dyspeptic symptoms. So if we see how a normal individual differs from a patient who has symptoms of dyspepsia. So whenever somebody takes a meal, so what happens is there is a relaxation of the fundus so that there can be accumulation of food in the fundus part. So if this relaxation is not there, so this patient will start having symptoms of early satiety. So immediately after taking a meal, they will start feeling fullness of the abdomen. So second thing which happens is the mixing of food in the corpus. So there should be proper contractions So like we talk about cardiac patient, they have tachycardia or bradycardia. So similarly in patient with dyspepsia, there can be either tachygastria or bradygastria. So the rhythm is either inadequate or it is too fast. So which can again lead to symptoms of dyspepsia. So third component is there is a proper coordination of the antropyloric region. So there is contractions of the antrum and there is a relaxation of the pylorus region followed by a relaxation of the duodenum. So in patients with dyspepsia, what happens is either there is a poor antral contraction or there is a functional contraction of the pylorus. So there is no mechanical obstruction. The pylorus is not providing way to the upcoming food bolus. So or there is a resistance by the duodenum. So all these factors lead to accumulation of food in the stomach for a longer period or leading to symptoms of postprandial distress, bloating sensation, nausea and vomiting sensation. So now coming to the approach to diagnosis and treatment. So if you have a patient who comes to your OPD with symptoms of dyspepsia, either EPS type, PDS type, or an overlap of that. So first thing which you have to look is whether your patient is more than 50 years of age or he is having any alarm symptoms. So what are the alarm symptoms which you should be looking for? So it could be either your patient, if your patient has dysphagia, your patient is having recurrent vomiting, your patient is having a significant weight loss, there is a GI bleed, or your patient has a family history of gastric cancer. So if any of this risk factor is there, you should directly refer this patient for an upper GI endoscopy. On the other hand, if your patient is less than 50 years of age, there are no alarm symptoms. So then we can broadly categorize these patients into 3 groups. So if your patient also has a GRD symptoms, so GRD symptoms include like classical symptoms are heartburn or regurgitation. Then you can empirically put these patients on PPI. So if there is a good response, treat as GRD. So if there is no good response, then we'll discuss further. Second group is patients who are on NSAIDs, probably due to osteoarthritis or due to any backache or any migraine, so or any other probable offending medication. So you should try to either stop these medications or try to switch these medication to a safer medications. So third group is patients who are neither on any offending medication and they don't have any symptoms of GRD. So in a high prevalence region like India, we are a high prevalence region. So we should opt for a test and treat strategy for H. pylori. So what is test and treat strategy? So I'm going to discuss in the upcoming slides. So if the test and treat for H. pylori is positive, we should treat for H. pylori. If it is negative and your patient is not responding, again, we should do an endoscopy to look for the causes of dyspepsia. So very important slide. So what is the role of endoscopy when we should consider doing an endoscopy? So how does it help in patients with dyspepsia? So normally what happens is we usually do an endoscopy with a 6 to 8 hours fasting. So if we find that the stomach is still full of food, there's residual food in the stomach. So that gives us a good hint that this patient might be having gastroparesis. So again, next we can diagnose gastric cancers. We can diagnose presence of any erosions or ulcers. And another important aspect is diagnosing of H. pylori. So we can visually see the features of H. pylori gastritis. There can be erosions, there can be nodular gastritis. Along with that, we can confirm using a rapid urease test as well as histopathology. I'm going to discuss that. So now coming to the test and treat strategy for H. pylori. So it can be broadly divided into either a non-invasive method or it can be invasive methods for H. pylori. So the non-invasive methods include the urease breath test. So it is not easily available. Otherwise, it's a good test to do. So second test is the stool antigen test. So it is available and usually the best recommended test for a non-invasive method of H. pylori. Serology, again, not recommended because it cannot differentiate between present and past infection. So among the invasive methods, as I discussed, that we can just visually see the gastric body and antrum to diagnose H. pylori. Along with that, we can take a tissue specimen. We can use rapid urease kits. We put the tissue specimen on the rapid urease kit And if the color changes from yellow to pink because of the release of urease enzyme, so we can confirm a diagnosis of H. pylori. So this we can immediately diagnose like within 15 to 20 minutes. So next, what we can do is we can send the same tissue specimen and we can send for histology or culture, which is again a very good method to confirm presence of H. pylori. PCR tests usually not recommended for routine practice. They are mainly used for research purposes. So briefly about gastric emptying study, if you are suspecting that your patient is having gastroparesis, there is a definitive role of nuclear scintigraphy. So in this test, we give food which is radio labeled, either a solid food or a liquid food. So we see how much time it is taking to empty at 1 hour, 2 hour, and at an interval of 4 hours. So the normal time taken for a solid meal, it is usually 90% of it empties within 2 hours, while there is complete emptying by 4 hours. While for a liquid food, majority gets emptied within 1 hour, and within 2 hours, the majority of liquid food gets emptied. So if there is the time taken is more than that, we can label these patients as having gastroparesis. So briefly about electrogastrography. So similar to like what we are doing for cardiac patients, ECG. So this is how an ECG machine looks like. So similar to ECG electrodes, we place 3 electrodes on the abdomen. So this helps us differentiating those patients who are having a functional pylorospasm. So there is no mechanical obstruction. So this pylorus doesn't allow the food bolus to go into the small intestine. So this group of patients respond very poorly to prokinetics, and there is a definitive role of balloon dilatation, or there is a new procedure called G-POEM, by which we can cut the muscles of the pylorus using just an endoscope. So with this background information, so I am going to discuss 3 cases with presentations of dyspepsia. They are having some different kind of presentation. So my first case is a 57-year-old female who is school teacher. The symptoms of bloating, discomfort, epigastric pain, nausea and vomiting, early satiety and anorexia. Now you can see there are both symptoms of EPS as well as PDS. The symptoms are there from last 1 year and they have worsened from last 2 months. The history of 6 kg weight loss, physical examination, BMI is normal, the vitals were normal. There is slight tenderness in the epigastric region. Hemoglobin slightly reduced, but the ultrasound abdomen, which is again a very important investigation, which should be done in routinely in all patients, was normal. So the differentials for these patients could be either a peptic ulcer disease or it could be a functional dyspepsia. So we went ahead with endoscopy in this patient. So it showed severe gastritis. You can see red spots distributed in the body and the antrum region, and took a biopsy from there. And we did a rapid urease test using this RUT kits. So this is how a normal kit looks like. This is a well area where we place the tissue specimen. So if the color changes from yellow to pink, so within 15 to 20 minutes, we can confirm our diagnosis of an H. pylori. So in our case, the H. pylori test came positive. So final diagnosis of functional dyspepsia with an overlap of both EPS and PDS type with non-atrophic gastritis due to H. pylori infection was made. So the treatment part will be discussed by Rajiv sir. So I will move on to the second case. So second case is a 35-year-old male who is a driver by profession. Again, there you can see there is postprandial fullness as well as epigastric pain. So both an overlap of EPS and PDS. Early satiety from 4 months. So now this patient also has a heartburn and belching, so which are usually seen in GERD. So patient was treated with PPIs as expected, esomeprazole, rabeprazole, omeprazole, various types of PPI tried, but there was poor response to treatment. Vitals were normal, ultrasound was again done, it was normal. So this is what the endoscopy looked like. Though there was no evidence of esophagitis, no ulcers, no erosions, but there was definitive evidence of a lax lower esophageal sphincter. So by Hill's grade, it was a 2nd grade. So probably indicating there might be some reflux, or this patient might be having a non-erosive reflux disease. So final diagnosis of functional dyspepsia with a GERD overlap was made in this patient. So coming to my last case. So this is a 42-year-old female, manager, sedentary lifestyle, 6-month history of intermittent postprandial bloating, fullness, early satiety. Now you can see this patient only has the symptoms of postprandial distress. There is no epigastric pain or discomfort, but this patient suffered from anxiety, lack of sleep, panic attacks, and she was prescribed PPIs, but the treatment was not successful in completely alleviating her symptoms. BMI slightly raised, vitals were normal, and endoscopy done in this patient was absolutely normal. There was no gastric or duodenal ulcers, no gastritis, and the RUT was negative for H. pylori. So final diagnosis of functional dyspepsia, which is a PDS type with an overlap of generalized anxiety disorder, was made in this patient. So with this, I end my slides and I hand over to Dr. Rajiv to discuss the management part.
At the outset, I'd like to thank Dr. Mali, being at the helm of affair, a team leader, for creating a beautiful place, which is a Gurukul for all of us in Punjab and Northern region. And thanks to Team Lupin for this wonderful academic platform in which we can share our ideas to our worthy physicians. Dr. Neeraj has made my talk very, very easy. He has elaborated how to diagnose a patient of functional dyspepsia and very beautiful giving 3 case capsules in which there is a different scene: functional dyspepsia with EPS, functional dyspepsia with GARD, and functional dyspepsia with generalized anxiety disorder. So now I'd like to take you everybody to the management of GERD, this functional dyspepsia. The objectives of my talk will be to discuss management approach to functional dyspepsia, what are the available treatment options, when to add prokinetics, how to choose right prokinetic drug, and role of ecoshiamide in this particular condition. And I'll be discussing same 3 case capsules which we have diagnosed in the previous talk. So in this talk, I'll be discussing the management guidelines of functional dyspepsia. One is Japanese guidelines, American guidelines, and Indian guidelines we'll be discussing. So first of all, coming to this management algorithm by Japanese Society, as we discussed by Dr. Neeraj, once a patient of functional dyspepsia, we're contemplating if we are thinking that this patient may be having some organic disease, then there is a need of endoscopy. If on endoscopy it is normal, or if there is features of H. pylori, we can take the H. pylori biopsy, RUT. If it is positive, we can treat. And once we have treated that patient, if there is a recurrence of symptoms, or even after 1 month, patient is not responding, then probably we are dealing with the functional dyspepsia. On the other hand, if the young patient is there, in which there is no indication of endoscopy biopsy, but we feel, because India being high prevalent area for H. pylori, if we feel that patient may be having H. pylori, but endoscopy is not indicated, in those patients, we can do stool antigen. If it is positive, we have to treat this patient with standard treatment of H. pylori, and we have to see the symptoms. If this was a case of H. pylori related functional dyspepsia, patient will improve. But if patient doesn't improve, it means again we are dealing with functional dyspepsia. So coming to these American guidelines, so now we have one patient of functional dyspepsia, as we are discussing since last 20-30 minutes, that there are 2 subgroups. One is EPS type, when there is postprandial distress syndrome, patients having bloating, early satiety, and gastric distension. On the other hand, there is epigastric pain as well as discomfort. So we believe that these are the 2 separate subgroups theoretically in which the plan will be different. In EPS, we can start with anti-secretic agents like PPI. If patient doesn't respond, we can go to second line therapy. We can add prokinetic or any other drugs. On the other hand, as per guidelines, in the patients of postprandial distress syndrome, we can directly start with prokinetic. So theoretically, it seems to be very simple. Next, please. But in real practice, what is happening, we are not seeing those patients in which they come with typically PDS or EPS. Because the data says that 1/3 patient they present with postparent distress syndrome. 1/3 they present with EPS symptoms. 1/3 can be combination of both PDS as well as EPS. But whether this is end of story, no, because the patient is coming as a whole for these features. So there can be overlap with GERD. There can be functional dyspepsia with GERD overlap. Patient may be having underlying IBS, but we are just thinking that because he has symptoms in the upper abdomen, so it can be functional dyspepsia with IBS overlap. We have to be very careful. The patient can be having functional bloating, or patient can be overlapping with functional constipation. So this is a real story which see in the routine patients. So what are the modalities available for functional dyspepsia? If patient is positive for H. pylori, we can give H. pylori eradication therapy. Then there is an anti-secretory therapy like PPI, but at present lately we have PCABs, but there is no role of PCAB at present in functional dyspepsia. Then of course the big armamentarium is prokinetics, which we'll be discussing. And the patients who will not respond to prokinetics, then there is a need to start TCA, tricyclic antidepressants, SSRIs and SNRIs. So in functional dyspepsia, when to add prokinetic? Because whenever the patient is having PPI is effective in epigastric pain syndrome, but there is no data of PCAB in functional dyspepsia. But there is a low response to proton pump inhibitors in postprandial distress syndromes. So there we can add prokinetics. They tend to improve symptom of fullness as well as postprandial nausea. So this is a consensus. These are the drugs available for postprandial distress syndrome. One is anti-acid suppressing drugs. Second is a group of prokinetics. Then there is a neuromodulators and psychotherapy. So today we'll be discussing the prokinetics used, which can be used for functional dyspepsia. And many prokinetics are available, but practically we see that the drugs which are efficacious, which are recommended and which are safe will be delving into. So the prokinetics has their features. So we are categorizing three main drugs used in clinical practice. One is ecosamide, second is etopride, and third is levosulpride. When you talk about first effect, which is a fundal relaxation effect that due to gastric accommodation, so ecosamide scores over all other drugs. It has strong fundal relaxation effect. Then there's etopride. It is very good molecule, but the fundal relaxation effect is very, very minimal. And levosulpride is again minimal or no effect on fundal relaxations. But when you talk about gastric emptying, so the improvement with ecosamide is moderate, but with etopride and levosulpride, this effect is very, very profound. Coming to safety and tolerability, ecosamide as well as etopride, they are very, very well tolerated drugs. But levosulpride, very good prokinetic, but have many neurological adverse effects. So in this case, when you talk about ecosamide versus etoprides, so because ecosamide increases the gastric accommodation, so the patients in which there is early satiety and fullness after meals, immediately after meals, then the role of ecosamide is excellent in this profile of patients. So ecosamide has been originally developed and approved in Japan in 2013. It is world's first drug approved for functional dyspepsia. The long-term phase 3 trials completed in European as well as in Japanese and US trials are available. No clinical significant safety concerns or cardiovascular ill effects on short and long-term use of ecosamide are there. So coming to the mechanism of action, why this drug is very effective and very, very safe? Because it is a novel gastroprokinetic drug with the dual action specifically on gastric synaptic acetylcholine. It enhances the acetylcholine release from enteric neurons. It reduces the acetylcholine breakdown due to inhibition of synaptic acetylcholine esterase activity. So with this, the more acetylcholine for more time, it results in enhanced gastric accommodation and enhanced gastric emptying. So coming to the pharmacokinetics, after single dose administration of ecosamide, the T half-life is more than 13 hours. It is metabolized to D-isopropyl by CYP cytochromes. 93% it is excreted in the feces, only 7% through kidney into the urine. So there is a low potential for a drug interaction with the other confounding drugs. So this is a very beautiful study, initial study, how icosapent increases the gastric accommodation reflex. This was a study done, it was double-blind, ultrasound-guided study. Gastric accommodation reflex as well as gastric emptying was studied. There was significant increase in gastric accommodation, that is 22% versus 5% in versus placebo after ingestion of 400 ml of liquid wheel. So there was significant increase in gastric emptying. So same as discussed with Dr. Neeraj, the gastric scintigraphy study pre and post after 2 weeks of icosapent therapy that shows there is an improved gastric accommodation and gastric emptying as compared to placebo. So coming to there are n number of studies, few studies. The first study is a long-term safety and efficacy of icosapent in functional dyspepsia, especially in post-parental distress syndrome, results from European phase 3 open label safety trial. So this was long-term safety and efficacy trial for icosapent. Number was more than 200. It was a European trial in which 100 milligram of icosapent was given 3 times a day for a year. So in all these studies, 4 evaluation score they were used. One was post-parental distress symptom score, quality of life score, work productivity and activity impairment scores, and overall treatment efficacy scores. So clinical usable is the Likert score. In some studies, they were 5 point. In other study, they were 8 point Likert score, in which they have taken the features of early satiety, postprandial fullness, bloating, epigastric pain, burning, nausea, belching, and heartburns. So in this case, what they have found, there was moderate to strong improvement with icosapent. Starting from week 1, it was 13%, then it was 40% at 12 week, and more than 70% week 52. So to conclude, this study shows that 80% of patients in this study took icosapent for more than 50 weeks, that is around more than 300 days. There were moderate to strong improvement, increased from 13 to 70% 52 weeks. The long-term safety of icosapent was very good. Only 9% patient reported at least one treatment-related emergency adverse events. So this was the aim and objective was it was multi-central, open-label, single-arm, long-term study in patients of functional dyspepsia. They were given icosapent 100 milligram 3 times a day for 48 weeks from 32 centers in Japan, and the aim was to investigate the efficacy and safety of icosapent. So in this case, as in the previous study, what they found, the overall treatment efficacy improvement was 26% week 1 and 61% at week 8. And this effect was persisting long term. So in this study, what they found, the functional dyspepsia symptoms started to improve from an early stage, that is week 1, and improvement effect was maintained even after a dose interruption. And the incident rate of adverse reaction was only 11%, they were mild. So after there are multiple RCTs, there was need to have real world efficacy and tolerability of icosapent. This was a trial, a study, real-time study from India. So this was real world efficacy and tolerability of icosapent in relieving meal-related symptoms of functional dyspepsia. The objective was to evaluate the efficacy as well as safety of this drug. So this drug was done in India, 63 gastroenterology clinics across India, in which more than 300 functional dyspepsia patients who were having meal-related symptoms, and it was involving all 4 zones of India. Male-female ratio was 3:2, and 40 years, more than 40 years patient were more than 60%. Symptomatology baseline was more than 70% they were having postprandial fullness, upper abdominal bloating, and 50% they were having early satiety. 1/3 patient they were having in addition epigastric pain, burning, few were having constipation and diarrhea. There were complete or significant improvement from postprandial fullness, upper abdominal bloating, and early satiety was around 79%, 74%, and 77% respectively. This study suggests the use of icosapent was associated with improvement of meal-related functional dyspepsia with very good safety profile. So this was very good meta-analysis of functional dyspepsia with icosapent. So in this case, what they found that the overall this drug was very efficacious and favorable safety profile was also there. The ecoschimite improved the symptoms of patients with postprandial distress syndrome. It shows significantly beneficial effect on elimination of individual function dyspepsia symptoms compared with placebo, and adverse effects were not significantly different between ecoschimite as well as placebo groups. The first patient was 57-year-old female, functional dyspepsia. She was having combination of EPS as well as PDS with chronic non-atrophic gastritis with H. pylori infections. So in this case, patient is H. pylori positive. So we believe that she is having dyspepsia because of H. pylori. Next. So what we did, we treated her with H. pylori therapy. Triple therapy was given, omeprazole, amoxicillin as well as clarithromycin for 14 days with lifestyle modification. So what can be done? After treatment of H. pylori, she is not responding. So what should be the other options if symptom persists after H. pylori eradication therapy? Next. So in this case, following H. pylori eradication, patient started on ecoschimite, 100 milligram 3 times a day. At 4 weeks, patient reporting significant improvement in her symptoms of bloating, discomfort, nausea, and vomiting after meals. She was advised to continue ecoschimite 3 times a day before meals with on-demand PPI and followed after 1 month, but she remained absolutely fine. Coming to second case, this was 35-year gentleman male, functional dyspepsia. This patient was having postprandial distress syndrome with GRD because there was lax G junction. He was having features of reflux also, GRD overlap. So in this case, already patient has taken multiple PPIs for 8 weeks. So what pharmacological management should be preferred in such cases? Double dose PPI because already patient is on PPI, or we can add PPI with prokinetic or any other therapy, and why? So in this case, already patient was on PPI, but patient was not responding. So apart from lifestyle modification, we started him on esomeprazole 40 milligram OD with ecoschimite 3 times a day along with antacids. And patient had complete resolution of symptoms, and patient was advised ecoschimite at least for 4 weeks again, and patient remained very well. So this was the third and last case. She was 42-year-old female with functional dyspepsia, postprandial distress type, but she was having generalized anxiety disorder. So in this case, patient was given initially pantoprazole with levosulpiride 25 milligram 3 times a day. So after 3 days of treatment, levosulpiride was stopped due to side effects such as headache, somnolence, as well as fatigue. And she was started on ecoschimite 100 milligram 3 times a day before meals for 4 weeks. And still partial resolution of symptom was there. So already we have done everything, PPI given, prokinetic, and she is not responding because the fact in this patient is that she is having generalized anxiety disorder. So probably these are the patients where we need to start tricycling antidepressant. In this case, we did same. We started her on amitriptyline 10 milligram once a day night time, and patient had significant improvement not only in GI symptoms but also in anxiety and lack of sleep. To summarize, the carry-home message of this talk is functional dyspepsia, the therapeutic options with proven efficacy, the therapies are very, very limited. The postprandial distress syndrome, there is a low response to PPI alone. The choice of prokinetic, whether it is etopride or ecoschimite, should be according to the clinical profile of the patient. Ecoschimite is a novel prokinetic drug having unique mechanism of action with proven efficacy and good safety profile. Ecoschimite is the world's first approved treatment for functional dyspepsia, but still we can have many patients who have refractory functional dyspepsia, and there is a need to escalate therapy, maybe with the tricyclic antidepressant, SSRIs, and SNRIs. With this, I end with my talk. Thank you from the team AGI, and hand it over to Dr. Mali sir for the discussion. Thank you.